Hi, my name is Moby Parsons, and I'm a shoulder arthroplasty surgeon practicing in Portsmouth, New Hampshire at the Knee, Hip, and Shoulder Center. I am one of the design surgeons for the Exactech GPS, or Guided Personalized Surgery Shoulder Navigation System, and this is my disclosure that I serve as a consultant for this project. Today's presentation is going to demonstrate the value of preoperative planning by showing specific examples of different glenoid anatomy, and to demonstrate how augmented components can be used to achieve the goals of preoperative planning and their utility. We are also going to introduce some controversies and unknowns about how we should be reconstructing shoulders based on premorbid anatomy and optimal loading mechanics. Why is planning so important? Well, glenoid anatomy is highly variable. Glenoid erosion is very common in shoulder degenerative conditions, and the degree of glenoid erosion and any necessary correction can be very difficult to quantify without advanced imaging and preoperative planning. The location of the glenoid vault, its walls, and its depth can also not be known simply by looking at the face of the glenoid. An adequate correction of pathoanatomy while minimizing bone loss and preventing implant penetration of the vault is essential. I'm going to take you now through a few interesting cases that we have come upon in our shoulder database and to discuss the value of this technology as well as some issues that may be controversial. This particular case brings up the controversy of which is better, restoring a patient's native anatomy or restoring optimal loading mechanics for the glenoid implant. This particular case shows one where the native retroversion is approximately -7 degrees, and these axial images also show that there is very limited posterior humeral subluxation, and this suggests that there's limited posterior glenoid erosion. You can see on the left-hand side of the screen is a case where we have chosen a standard anatomic glenoid implant placed at 7 degrees of retroversion. On the right side of the screen, we can also choose an 8-degree posteriorly augmented anatomic glenoid and correct this to 0 degrees of retroversion. In both cases, you can see that there is minimal bone loss with complete backside seating of the implant. And the real controversy here is whether or not we should be placing a standard implant in situ or an augmented implant corrected back to quote-unquote neutral relative to the Friedman axis. And I would argue that we don't know the answer to this question yet, and when we look at the surgeon variability and how cases like this are planned, we see that there is a wide spectrum in how implants are placed and varying degrees of glenoid version correction for cases such as this. Here's a similar case of looking at position of the cage and implant version. On the left-hand side of the screen, you can see that it's a standard caged glenoid component has been selected and placed at 8 degrees of retroversion, which is roughly in line with the patient's native. You can see that the cage sits nicely within the vault at this native 8 degrees of retroversion. You can also see that there is limited posterior humeral subluxation in this case, and this may suggest that 8 degrees of retroversion is normal for this patient. On the right-hand side of the screen, you can again see that we've chosen an 8-degree posteriorly augmented glenoid implant, and when we place this in 2 degrees of retroversion, which minimizes bone loss, you can see that the cage is positioned slightly more posteriorly and butting up against the backside of the glenoid vault, and perhaps even penetrating that vault to a slight degree, because this is a narrow glenoid vault. And so again, this is controversial whether or not we should be augmenting a case like this at 8 degrees of retroversion to achieve a more neutral correction, or leaving this in situ, given that the humeral head remains fairly well centered on these preoperative views. Here's an example of a glenoid with a very narrow vault. This is a small component that has been chosen here, and you can see that the cage is penetrating the backside of the vault on these views. We can switch it to the two-dimensional view here, and again you can see the cage penetration into the spinal glenoid notch. We can then convert this to an 8-degree posteriorly augmented component and tilt this into retroversion to minimize bone loss. When we center this on the glenoid, you can see again there is penetration of the vault because it is very narrow, and we can then convert this to the sagittal view here. We can dial in our optimal inclination and then go back to the three-dimensional view. Here again you can see there's penetration of the posterior inferior peg in the central cage. We can move this implant anteriorly and we can minimize that cage penetration by anterior repositioning of the implant. Again, this would be very difficult to achieve simply by a freehand or eyeballing technique. Here's another case looking at the interaction between obtaining optimal version correction and integrity of the glenoid vault. This is also another case with a very narrow glenoid vault. Again, a small implant has been chosen. Here we can see the Friedman axis in yellow, and we can begin to tilt this implant into retroversion here to try to minimize vault penetration and optimize the position of the cage within this narrow vault. Again, we can toggle to the sagittal view in 2 dimensions here to add some inclination so that we can minimize inferior bone loss. The average inclination in our series is about 5 degrees of superior inclination, which is likely normal. Toggling to a 3-dimensional view now, we can see we have good positioning on FOSS, but we do have some posterior penetration of the cage. And again, we can shift this implant anteriorly, and now we have just very slight penetration of the anterior inferior peg, but our cage is fully seated in the bone. Again, without the aid of this preoperative planning software, I think it would be very difficult to optimize implant position to ensure that there is limited to no penetration, as well as to simultaneously correct the version and ensure optimal backside seating of the implant. Here's a case contending with severe medial wear of the glenoid. And in cases like this, you can see that glenoid vault is very narrow. It's also very shallow. And in cases like this, some degree of cage penetration is likely unavoidable, but navigation allows the surgeon to minimize it while still putting the glenosphere in a favorable position and while simultaneously achieving optimal backside coverage, optimal implant selection, and optimal fixation and version correction. Here you can see we've chosen a standard reverse baseplate. There's some degree of anterior penetration here, as well as some degree of posterior penetration. And we will now adjust the version as well as other features to try to minimize this penetration as much as possible. If we shift it up, you can see we have slightly better bone available around the base of the scapular spine. And we can continue to adjust the position of this and also check once our glenosphere is placed that we can try to avoid scapular notching. This is a 38mm glenosphere. We can lateralize this with expanded glenospheres and go up to a 42mm glenosphere. We can add some inferior tilt to help reposition our cage in the bone. If we shift it anteriorly or inferiorly, we can try to lessen the risk of notching, which can be a problem when there is severe medial wear because there is minimal scapular neck to avoid contact of the implant with the bony scapula. Here's a case where a 16-degree posteriorly augmented anatomic glenoid is the optimal implant of choice. This is a large glenoid on a 3D en-face view, and we can then toggle this to an axial two-dimensional view, which shows us the degree of retroversion relative to the Friedman axis. Currently, we have an 8-degree augment selected, and when this implant is seated, you can see that the 16-degree now selected here is going to provide less bone removal and yet allow us to correct this severely retroverted glenoid back to relatively neutral retroversion while still keeping the central fixation within the middle of the glenoid vault. Again, we can see on the three-dimensional views it's nicely seated. There's no penetration. And we've reconstructed our version back to relatively neutral. Here's a case where we chose a superiorly augmented reverse base plate. You can see there's quite a bit of superior wear in this case. There's a large anterior osteophyte which can be removed, which gives the appearance that there's retroversion, but you can see on this axial 2D view there's actually not a lot of retroversion in this case once that osteophyte can be removed. So there's no posterior augment. This is a purely superiorly augmented base plate. And again, this can be positioned so that the cage is optimally centered in the vault, allowing minimal bone removal and optimal seating. This is at 5 degrees of retroversion. And here you can see with this superior glenoid wear, the utility of an augmented component in minimizing inferior bone removal and yet keeping the inclination around 0 degrees, which prevents the risk of superior instability or shear forces on the reverse base plate. Here we can play around with the glenosphere and look for the optimal position of the base plate that will prevent bony impingement against the coracoid or inferior scapular notching. And this is a 42 millimeter standard glenosphere. There you can see if I move it anteriorly, there's slight cage penetration, and so I'll move it back to avoid any penetration of the cage through the glenoid vault. This is a case showing a combined posterior superior augment for a case with a combined wear pattern. This again is a reverse shoulder replacement. You can see we can first rotate this base plate so the holes are lined up with the neck of the scapula and the coracoid base. And again, toggling on these two-dimensional views, you can see there is both superior and posterior wear. This augment combines the 10 degrees superior with the 8 degree posterior. And again, I can adjust the inclination and version to optimize the implant seating, minimize bone removal, and make sure that my central cage is optimally positioned in the glenoid vault. And again, we can place our glenosphere to determine how to reduce the risk of scapular notching or any type of impingement here. Go back to the three-dimensional view. There's some osteophytes that can be removed. And again, we can select our various different glenosphere options that we feel will best restore the offset of the remaining rotator cuff while limiting the risk of notching inferiorly. Here's a case looking at scapular notching. This case shows again there is fairly considerable medial glenoid erosion, and in fact in this case there's some inferior glenoid erosion, and you can see how short the scapular neck is. And these are cases where the risk of notching is higher because there's not that long pillar between the glenoid face and the scapular neck, predisposing these patients to risk of inferior impingement when the arm is in adduction. Here, in order to achieve clearance beneath, the base plate has to be positioned fairly low and a larger glenosphere used. This is a 46 millimeter glenosphere, which is not something that comes conventionally and has to be custom ordered. But you can see with preoperative planning, you can determine in advance of the case that this implant may be necessary to avoid scapular notching and have it on hand if needed. Here's an extreme case of retroversion, and this is really about optimizing vault penetration when you're dealing with these cases of extreme wear, where some degree of residual retroversion is going to be necessary, some degree of bone removal is going to be necessary, and some degree of vault penetration may also be necessary, but the planning software can help you minimize all of these features in favor of maximizing durability of fixation. Again, you can see extreme pathologic wear in this case, and we've chosen a combined augment to deal with this. You can see there's going to be some bone removal and some vault penetration there. And if we increase our base plate retroversion, we can minimize the penetration, minimize some of the anterior bone removal. And again, some degree of bone penetration is going to be necessary, and it's really just a matter of how we can capitalize on this technology to minimize the amount of bone destruction, as well as intraoperatively help us place this extremely difficult base plate placement in a very accurate and precise fashion. These are cases where I think the value of this technology speaks for itself, where you can see how much variability in the planning can take place as we continue to make adjustments to really try to optimize this placement. And here you can see I've limited the penetration to as little as possible. I've prevented scapular notching as much as I can here with the selected glenosphere. Again, this is a 46 millimeter glenosphere. And I would argue that there's no way that that could be achieved simply by eyeballing it. So again, in these extreme cases, this technology is extremely valuable in both the planning and the navigation phase. So in summary, hopefully you can appreciate from these cases the importance of planning and optimizing implant placement, particularly in cases of moderate to severe glenoid wear. Given the frequency of erosion, the use of augmented implants is really very valuable in allowing correction of pathologic version while minimizing bone loss. Our study group has shown, after planning hundreds of cases, that augmented glenoids and base plates are used in more than 50% of cases. And as you can see from earlier on, we still have some unresolved issues, as evidenced by the variability between how surgeons will plan the same case. And the ultimate goal of our platform and continued research is to help eventually determine the optimal implant position for any given case that will maximize its durability and function. I want to thank you for listening to this presentation.